Hello, my name is Tracy Sweetan, and today I'm going to talk about pacifier use and sudden infant death syndrome. Sudden infant death syndrome, or SIDS, is defined as the sudden death of an infant younger than 1 year of age, which remains unexplained after a thorough case investigation, including performance of a complete autopsy, examination of the death scene, and review of the clinical history. SIDS is the leading cause of mortality for infants between 1 month and 1 year, with the incidence of deaths occurring between 2 to 4 months of age, and 90% of cases occurring before 6 months of age. In 1996, the American Academy of Pediatrics, or AAP, released the Back to Sleep campaign to help reduce the incidence of SIDS. However, from the most recent data released in 2014, SIDS still remain the leading cause of death for infants 1 to 12 months old, with 38.7 deaths per 100,000 live births. Identified preventative factors for SIDS includes placing babies on their back to sleep, using a firm sleeping surface, keeping soft and loose objects away from the sleep area, keeping the room at a comfortable temperature, and avoiding smoking while pregnant and near the baby after birth. Pacifier use remains controversial among parents of newborns due to the concerns that it can lead to poor hygiene and indulgent behaviors. Currently, around 75 to 85% of children in Western countries use a pacifier. Some benefits of pacifier use include decreased hospital stay, earlier transition to bottle feeding from enteral feeding, and improved bottle feeding performance in preterm infants. Pacifier use has also been associated with mild analgesic properties, especially when used for minor procedures. Risk factors that have been associated with pacifier use include early breast weaning, an increased risk of otitis media, and adverse dental effects such as misalignment of teeth, open bite, and cross bite. Pacifier use has been suggested to have protective factors against SIDS and is currently recommended by the AAP as a risk reduction strategy. The exact mechanism of how pacifier use prevents SIDS is unknown, but current theories include that it may decrease the likelihood of rolling into the prone position while sleeping, helps maintain airway patency, may decrease gastroesophageal reflux and sleep apnea, or possibly increase the respiratory drive with carbon dioxide retention. However, the evidence of the use of pacifiers during sleep and its effect on SIDS is typically considered weak when compared to the modifiable risk factors listed in the previous slide. In the following slides, we will review 3 recent research articles that evaluated pacifier use and its effect on SIDS. Study 1 was a population-based control study that was conducted in 10 counties of Northern California and in Los Angeles County in Southern California from 1997 to 2000. SIDS cases were identified from cases that were reported to the California Department of Health Services and the coroner's office in LA County during that study period. Eligible participants were mothers of any infants with confirmed SIDS diagnosis who lived in one of the participating counties and spoke either English or Spanish. During the study period, 185 cases were identified. To identify controls, researchers used data from birth certificates to identify all eligible births, and infants were randomly selected from the same county in which the dead infant had lived. Controls were matched for maternal race, ethnicity, and age of interview for controls was matched to the age of death for cases. This study aimed to measure pacifier use during sleep and the risk of SIDS after adjusting for confounding factors. The study showed a 90% reduction of SIDS risk when infants used pacifier use during sleep, with an odds ratio of 0.08. This study also showed a consistent trend towards the use of a dummy during sleep being associated with a greater reduction of risk when the infant was placed in an adverse sleep environment, such as sleeping prone or on the side, which had an odds ratio of 0.66, or sleeping on soft bedding with an odds ratio of 0.26. Strengths of this study included that results were consistent with other studies on this topic. The prevalence of pacifier use in the control group was comparable to other U.S. populations that have been previously reported. However, some weaknesses included a small sample size, a low participation rate among eligible participants. However, information that was obtained from birth certificates of all eligible infants was used regardless of whether the mother participated in the study or not. And since this is a case control study, it does not provide proof of a causal relationship between pacifier use and SIDS. Study 2 was the German SIDS population-based case control study conducted between 1998 and 2001 in an area where around 50% of births occur. During the 3 years of the study, 2.3 million live births occurred in this region. Of these births, 333 SIDS cases were recruited and matched with 998 control infants. They were matched for age, gender, region, and sleep time. Control infants were born 4 to 6 weeks after the case infant, so that by the time the interview was performed, they were at the same age as the case infant. This study paid special attention to identify multiple risks in the infant's sleep environment that can lead to SIDS, with the protective use of a pacifier being one of the factors measured. Other factors measured in the study included type of bedding used, bed sharing, position infant was placed to sleep, pillow use, and a waterproof layer used in the infant bed. The data was adjusted for sleep position, breastfeeding, smoking during pregnancy, economic status, maternal age at delivery, bed sharing, previous live birth, birth weight, and extra heating of the infant. Pacifier use during the last sleep or reference sleep was associated with an odds ratio of 0.39, showing a protective effect against SIDS. Pacifier use during sleep in the last 4 weeks was associated with an odds ratio of 0.49, again showing moderate protective qualities. Strengths of the study included that it was conducted after the Back to Sleep campaign, which promoted a supine sleeping position. This Back to Sleep campaign resulted in a large decrease in SIDS death, making this study relevant to the current situation in most developed countries. The results of this study were also consistent with other findings from studies conducted in regards to pacifier use in SIDS. Weaknesses of the study included that participants in the control group were more likely to be socioeconomically advantaged. Information on the type of clothing used during last sleep was not gathered. Therefore, the environmental temperature was not able to be calculated to know whether the infant was over or under wrapped. And a small number of cases were used in the study, requiring additional studies to be conducted to confirm these findings. For Study 3, this study analyzed data from the Chicago Infant Mortality Study, or SIMS. The goal of this study was to examine risk factors for SIDS and other sudden unexplained deaths during infancy, with the principal goal of gathering information to aid in eliminating disparities in post-neonatal infant mortality between African Americans and whites. At the time of this study, African American infants were 3 times more likely to die from SIDS versus white or Hispanic infants. SIMS enrolled all Chicago resident infants from birth to 1 year who died suddenly and unexpectedly between November 1993 and April 1996. The study analyzed data for 20 SIDS cases and 260 controls. The controls in this study were living infants who were matched to each case infant by maternal race, ethnicity, infant age, and birth weight. The goal of this study was to determine if pacifier use modified the association between specific factors known to affect SIDS, such as sleep position, maternal smoking during pregnancy, bed sharing, and breastfeeding, and SIDS itself. The data was adjusted for maternal age, marital status, maternal education, and adequacy of prenatal care. The study found that pacifier use reduced the risk of SIDS by 70%. Pacifier use was associated with an odds ratio of 0.30, indicating strong protective properties. Without pacifier use, prone sleep position, maternal smoking, and bed sharing were associated with an increased risk for SIDS. However, with pacifier use, the odds ratio for prone sleeping, maternal smoking, and bed sharing ranged from 0.28 to 0.76, showing the protective properties of pacifier use when combined with adverse sleep environment characteristics. Strengths of this study included that it was the largest case control study of that time conducted in the U.S. in a high-risk population for SIDS. This study was based on similar key health indicators for the U.S., making it generalizable to other high-risk populations within the U.S. The results of the study remained consistent with other SIDS case control studies that have been conducted. Weaknesses included that it was implemented before the Back to Sleep campaign when more infants were placed to bed in a prone sleeping position, and that it wasn't able to attribute a causal effect between any individual risk factor and SIDS. As you can see with the three studies presented, the confidence interval did not include 1, making the results of these studies statistically significant. However, since these were all case control studies, they were unable to prove a causal relationship between pacifier use and SIDS. All 3 of the studies contain the potential for selection, reporting, and interviewing bias. And these studies tried to control for multiple confounding variables, with the most common being maternal age, sleep position, smoking during pregnancy, and education. Since the disease or SIDS is rare, the odds ratio approximates relative risk. These studies showed a moderate to strong association between pacifier use and the reduction of SIDS. None of the studies provided biologic plausibility, as it remains unknown how pacifier use protects against SIDS. All 3 study findings were consistent with results published by other studies conducted in this area. Since some infants in both the case and control groups used pacifiers with varying frequency, researchers were unable to say that not using a pacifier leads to SIDS or even increases the risk. A dose-response relationship in regards to the amount of exposure to pacifier use was not seen in these studies. In conclusion, these studies showed a moderate to strong protective association between pacifier use and the reduction in SIDS. A stronger association between pacifier use and decreased risk of SIDS was noted in the studies when pacifier use was combined with adverse sleep environments or other known SIDS risk factors such as side or prone sleeping, bed sharing, and the use of soft bedding. Even with limited research, current AAP guidelines encourage offering pacifiers at the onset of sleep to infants less than 6 months of age. In order to have fewer adverse effects on breastfeeding, the guidelines recommend not introducing a pacifier to breastfeeding infants until 1 month of age. Pacifier use should not be forced on the infant or reinserted during sleep if the infant spits it out. Future research needs to be conducted with larger population samples to be able to determine a causal effect between pacifier use and SIDS, and the number of cases used in these studies were small. Thank you for taking the time to listen to my presentation. I hope you enjoyed it.